I am very happy to introduce Professor Abdul Manan. Professor Abdul Manan is working as a professor and chairman of the Department of Neonatology of Bangabandhu Sheikh Mujib Medical University, the apex of the Medical Institute in Dhaka, Bangladesh. He's also the Secretary General of Bangladesh Perinatal Society, Vice President of Bangladesh Neonatal Forum, and also Deputy Secretary General of Western Region of Federation Asia and the Oceania Perinatal Society. He's a honorable member of the National Technical Working Committee of Newborn Health in Bangladesh. He has more than 100 scientific articles published in reputed journals. Professor Mannan is also involved in different national activities related to newborn health, which are being implemented by government of Bangladesh. As an university faculty, Professor Mannan is involved in patient care, student teaching, and also research. Thank you very much, Professor Mannan, for being here with us today. And the floor is yours. We can see your screen. It's very good. Looking good.
Thank you, Flavia, for your kind introduction. My salam to Professor Shahidullah sir, my teacher, my mentor, and participants from home and abroad, my colleagues, representative from Bangladesh, India, Pakistan, Nigeria, and other countries. My students is here. So, assalamu alaikum and very good afternoon to all. So, this is the timeline of my presentation. Let's start one case scenario. Just one baby, this is 33-week newborn, birth weight is 1450 gram, admitted with the problem of respiratory distress. The mother delivered the baby by cesarean section, and mother received only one dose of corticosteroid 1 hour prior to delivery. So, question is, what is the possible diagnosis? Should we start antibiotic? So this is another baby. This is 29-week baby, very low birth weight, admitted in NICU with the diagnosis of respiratory distress syndrome, and the baby is on CPAP. And now the postnatal age is day 6. And the baby developed less activity, apnea, subsequently cold extremities, tachycardia, poor perfusion, and the respiratory support has been increased. X-ray is normal and septic skin level positive. So what is the assessment and how to manage this baby? So this is the outline of my presentation. I'll be talking on introduction, pathogenesis, diagnosis, and management. And under these headlines, I'll be talking on definition, epidemiology, classification, natural defense, pathophysiology, clinical manifestation, investigation, septic shock management, antibiotic use, resistance, and stewardship. So here we can see the three terminology. This is infection, sepsis, and systemic inflammatory response syndrome. So these all three are not the same. So all infections are not sepsis. And if we diagnose a baby with sepsis, there must have systemic inflammatory response. But all systemic inflammatory response is not due to bacterial infection. There are other causes for this. This is hypoxia, trauma, and also might be other causes. So in terms of global burden of neonatal sepsis, here we can see the 11 million sepsis-related fatalities, around 49 million instances of sepsis globally. This is published in Lancet in 2022, and this is basically the data of under 5 mortality and the sepsis. And here I am sharing another facts, that is there is 1.3 to 3.9 million annual neonatal sepsis cases. This is also a report from WHO, and 24% of neonatal deaths are caused by severe neonatal infection. And this is more common in low and middle income countries. And hospital acquired infection, this is 4 to 56% deaths depending on the study and geographical area. And this is the under 5 and newborn causes of deaths in Bangladesh. Left-hand side, we can see the under 5 mortality. Here, around 60% neonatal deaths are due to under 5 deaths are due to neonatal causes, and the significant number, around 20% neonatal deaths, are due to septicemia. So, what are the classification of neonatal sepsis? We can classify as early onset, late onset, and also healthcare associated infection. The early onset sepsis, which usually happens within 72 hours of age, and source usually maternal origin. And in late onset sepsis, the source either from hospital or from community acquired. So why newborn are more prone to develop septicemia? There are many risk factors from maternal side which may cause sepsis to the newborn. Prematurity, again, very, very vulnerable. The immature immune system, underdeveloped physical barriers, and other risk factors for newborn which are prone to develop infection to the newborn. Here we can see three barriers. One is respiratory. Second, we can see this is the skin, very important barriers. And last one is gut. So I'll talk about the skin and also the gut, I mean intestine. Here we can see if we venipuncture or insert peripherally inserted a central catheter or IV cannula, and also we can use the tip. This may cause the injury, and we can introduce the organism directly to the blood. And also here we can see the intestine and also luminal bacteria, that is the microbiome. There is a very good homeostasis, and this can prevent the bacterial invasion into the bloodstream. And when we are using antibiotics and the baby is in stress or in hypoxic condition, this homeostasis, there is disruption, and the organism may enter into the bloodstream. So please, we have to keep in our mind when we venipuncture or we put any IV cannula or give any antibiotic. So we have to think second and third time, two times, three times, whether it is really indicated or not. So this is in very short about the pathogenesis of neonatal sepsis. Basically, this is a very complex procedure. I have made it in very simple way. When any bacteria enter into the blood, subsequently there might be cytokine storm, then anticoagulants cascaded, then also chemokines, anti-inflammatory, pro-inflammatory cytokines is released there, and subsequently what happened? There is vasodilatation, also leakage of capillaries, subsequently microcirculatory and mitochondrial damage, and septic shock that might lead to multi-organ dysfunction syndrome. And here I will share the risk factors of early onset sepsis. I have taken these 7 points from AIMS protocol in neonatology, which is published in this year. This is spontaneous preterm labor, foul smelling liquor, preterm labor, pre-labor rupture of membrane more than 24 hours, confirmed or suspected intrauterine inflammation or infection, or both. Nowadays, it is called triple I. This is basically the and a synonym of chorioamnionitis. Single unclean vaginal delivery, vaginal examination, prolonged labor, severe perinatal asphyxia. So these are 7 points of early onset neonatal sepsis. And what about risk factors of late onset neonatal sepsis? Among all, I would emphasis on the invasive procedure, mechanical ventilation, inappropriate use of antibiotics, and administration of parenteral fluid. And in community, acquired infection, poor hygiene, poor pot care, bottle and formula feeding. Basically, the risk factors in community acquired also may happen in hospital acquired infection. And now this is the organism in early onset sepsis and late onset sepsis, E. coli, Klebsiella, Pseudomonas, Staphylococcus, Enterococcus. In late onset sepsis, Acinetobacter, Klebsiella, Pseudomonas, but we never find any group B Streptococcus in our country. So I'm sharing the organism in last 1 year. This have isolated in our department the number one organism in Klebsiella and Acinetobacter, then Candida, Pseudomonas, Staphylococcus. These are the other common organism isolated from our department. So among the clinical features here, this is the common clinical features in early as well as late onset neonatal sepsis. But in early onset neonatal sepsis, the main clinical feature presentation is involving the respiratory system, that is the respiratory distress. And in late onset neonatal sepsis, the main clinical presentation is involving mainly the CNS system, I mean meningitis, that is manifested as lethargy, refusal to seek, food perfusion, like that. One point I want to mention here, that is, if a baby is clinically septic, usually at least two or more clinical features usually evident there. RDS, TTN, mucor syndrome, GI perforation, then obstruction, congenital heart disease, hypoxic ischemic encephalopathy, torsion infection, all these can confuse the diagnosis of neonatal sepsis, but sometimes this may be associated with neonatal sepsis. Respiratory failure, septic shock, disseminated intravascular coagulation, convulsion, SIAD, hyperglycemia, metabolic acidosis. These are the common complications of neonatal sepsis. All these 5 investigation, I mean total leukocyte count, NC, IT ratio, microRESAT, C-reactive protein, this can be done in district level hospital, but this is not the confirmatory. But some of clinician, they usually, if there is screen is positive, they take the baby is clinically septic. So, but this is not confirmatory of neonatal sepsis. We can take the body fluid for culture and sensitivity, like blood, this spinal fluid, tracheal aspirate, and also some babies may need X-ray, ultrasound, and CT scan of brain. So blood culture is the gold standard, and please, we should keep in our mind that aseptic precaution procedure is a highly recommended, as we have to depend the culture sensitivity report to, to which antibiotic will prescribe. So this is the indication of CSF study, very clear cut. 3 indications in early onset sepsis 2. This is if blood culture is positive and if the clinical pictures consistent with septicemia. In late onset sepsis, basically all cases we have to do CSF study. Now the management of neonatal sepsis. Definitely, supportive care is very crucial. I mean, thermal care, airway, breathing, circulation. And I would emphasize that at least district level, there should be provision of blood bank, as because some septic baby may need blood transfusion, FFP, and platelet concentrate. One study findings that the excess transfusion in septic baby with eschema, there is significant reduction of neonatal deaths. So when we should start antibiotic? In case of early and late onset sepsis, if there is strong clinical suspicion. And additional 3 points is here in case of early onset neonatal sepsis. That is, if there is chorioamnionitis, this is the only indication where we can prescribe the antibiotic. And if there is presence of 3 or more risk factors and 2 or more risk factors with positive sepsis screening. So these are the indications of antibiotic in early onset sepsis, and this is the late onset neonatal sepsis. How to monitor and follow up the baby? Definitely, we have to see the baby's activities, then responsiveness, vital signs, capillary refill time, and also we have to do the systemic examination and laboratory investigation, complete blood count, C-reactive protein, electrolyte, calcium, serum creatinine, ABG, X-ray ultrasound, depending on the severity and system involvement of the neonatal sepsis. And if we see in district level hospitals, if there is respiratory failure and baby needs mechanical ventilation, then shock not responding to inotros, persistent or refractory conversion, development of DIC, we have to transfer the baby to a higher level. Prophylactic antibiotic in prematurity, in use of IV fluid, meconium stained baby, transient tachypnea of newborn, umbilical catheterization, excess transfusion. Some of our colleagues, I'm sorry to say, in district level hospital or upazila level hospital, they sometimes use IV fluid as well as antibiotics. So, but there is no recommendation, no recommendation. Rather, this will harm the baby. This is the antibiotic regimen from WHO Pocketbook of Hospital Care for Children. The first line is ampicillin gentamicin, and third generation cephalosporin is for late onset neonatal sepsis. Duration of antibiotics I've taken from our BSMMU protocol. If there is meningitis, we have to give 21 days, culture positive sepsis 14 days, clinical sepsis with screen positive 10 days, and clinical sepsis but not screen positive 7 days. And if we see baby is fine, only risk factors are there. Safely we can discontinue antibiotic after getting culture report within 72 hours of postnatal age. Septic shock. How to recognize the septic shock? The first line is tachycardia. Subsequently, the baby develop prolonged capillary refill time, poor distributivities, pale or motting of skin, lethargy, and low blood pressure is the late sign of shock. We should not wait to treat the baby up to development of low blood pressure. This is very simple algorithm to manage septic shock. First, ABC, air breathing circulation. We have to correct the hypoglycemia, hyperglycemia, hypocalcemia, and definitely we have to start the antibiotic. Then we need to push isotonic normal saline, initially 10 ml per kg and subsequently 20 ml per kg. Then if there is no improvement, we can give dopamine, and dobutamine is preferred for cardiogenic shock. And if there is no improvement, we can consider epinephrine, and the last drug is the hydrocortisone. So we are treating baby in NICU, and after treatment, we are discharging the baby. This is not the final. This baby might develop subsequently cerebral palsy, hearing and visual impairment, then chronic lung disease, increased risk of recurrent infection, growth retardation, and behavioral and emotional disorder. So all these points we need to keep in our mind. I'm sharing a systematic review and meta-analysis in this regard. This article is published in a renowned journal. This is Children. And here the findings is very preterm infants with neonatal sepsis are at higher risk of impairment such as cerebral palsy and neurosensory deficit compared with the infants without sepsis. Odds ratio is 3.18 and 95% confidence interval. Now, a few words about antibiotic resistance. When bacteria, virus, fungus, and parasite no longer respond to antimicrobial medicine, and infections become very difficult to treat and increasing the risk of disease spread, severe illness, disability, and deaths. 1.27 million global deaths in 2019 directly responsible due to bacterial antimicrobial resistance. And on the right hand side, we can see the 1 million US dollar additional healthcare cost by 2050. This is World Bank estimate. This is due to antimicrobial resistance. So antimicrobial resistance puts many of the gains of modern medicine at risk. Here I'm sharing one culture sensitivity report from our department. This is the last 6 month reports. Here we can see the colstin, which was around more than 90% sensitive. Now we see only 7% are sensitive to the colstin. And these are the very, very alarming situation. Now this is one report. Here we can see the isolated organism in Klebsiella pneumoniae. And you can see here all the antibiotics are resistant. Only intermittently sensitive is tigacycline and colistin. So very, very concerning. Antimicrobial stewardship. So this is the collective set of methodologies that enhance the appropriate use, reduce the deleterious effect, and awareness like antibiotic resistance, toxicity, and economic burden. And we have to enhance the infection prevention and control, controlling the source of infection, prescribing antibiotic when really needed, and also the appropriate dose, duration, route, supporting surveillance, educating staff, and supporting the interdisciplinary approach. So 5R of antibiotic stewardship. This is first the responsibility. We have to keep in our mind that antibiotic is a drugs that can kill the baby, that can harm the baby. And we need to prescribe the antibiotic when it is really indicated. And through this, we can reduce the use of it. And refinement means we have to give the right drugs, right dose, right route, and right duration. And can we replace? In some extent, we can replace if we can use. There are evidence I'll show later on. The handoff, then breastfeeding, then kangaroo mother care, use of probiotics. That can helps in reducing neonatal sepsis. And also we have to review periodically the antibiotic sensitivity pattern, and we have to make the antibiotic policy. This is the slide taken from WHO recommendation about access, watch, and reserve. So here, main three issues here. Here is prematurity, prolonged rupture of membrane. This is not the indication to prescribe antibiotic. And when we prescribe any antibiotic, we have to keep in mind that clinically and laboratory the baby is septic. At least clinically the baby is septic. And we can discontinue antibiotic when the report is now negative, and we need to continue the antibiotic if the blood culture is positive. So all these points we have to keep in our mind. Some recommendation for improving neonatal outcome. Uh, First, I will share about the IKMC. WHO now recommending the IKMC for. Here I will share the how IKMC is reducing in terms of neonatal sepsis incidence as well as the mortality. Here we can see the reduction of neonatal sepsis is 24% and mortality due to sepsis is 37%. So if uh, mother can initiate early initiation of breastfeeding within 1 hour, one study findings is around 33% reduction of neonatal mortality. So WHO is recommending uninterrupted skin-to-skin care, I mean zero separation, and all mothers should be supported to initiate breastfeeding as soon as possible, at least within 1 hour after delivery. And hand washing, again, WHO is strongly emphasizing this is cost-effective and essential intervention to prevent infection, and ensuring proper hand hygiene in an ICU can reduce incidence of neonatal sepsis 50%. So, in conclusion, I can say that sepsis is the leading cause of neonatal deaths, especially in NICU. Definitely, early identification and proper supportive care and prompt management is crucial for better healthy outcome of septic newborn. Blood culture is the gold standard, and develop antibiotic policies, then antibiotic stewardship, and adopt cost-effective holistic intervention to ensure outcome of septic newborn. So I must acknowledge some name, my colleagues who have given me the tremendous support for preparing this presentation. Dr. Sadika Chaudhary, my colleague, she's the assistant professor. Dr. Ismat Jahan, she's also assistant professor. Dr. Flavia Rosa Mangret, consultant neonatologist from WHO. Dr. Aisha Siddiqa, Dr. Mehdi Hassan, Dr. Sabir Ahmed from Projanmo Research Foundation, and Dr. Sabrina Tisha also from Projanmo Research Foundation. So thank you, everyone.
Thank you. Thank you very much, Professor Mannan, for this thorough presentation and for sharing your experience with us, your vast experience with us. I would like to emphasize that this is a very complicated topic, especially for the audience that we're expecting to reach, which is district hospitals that mostly do not have access to blood cultures or even to CRP, and face themselves challenged daily on their choice of when to give antibiotics to these babies. And we understand that it's difficult, and these were some examples. We also understand that some countries have different protocols. So thank you, Dr. Mannan, for sharing the protocol that you're using, the protocols for Bangladesh and also from India. I'm sure Ethiopia has also their own protocols, as Nigeria does, as also Pakistan. Our goal is not to replace any protocol. So WHO doesn't have a specific protocol concerning when which babies will receive and which septic screen, what's the role of the septic screen, but we definitely recommend the blood cultures. And we definitely recommend to treat based on clinical signs. So it's very important to take into consideration clinically the babies, and to stop antibiotics as soon as the infection is ruled out. So we are more working on antimicrobial stewardship now. We have a high level of antimicrobial usage in all sites, which I will be able to share with you. I would like to know for now if there are any comments or any questions for Professor Mannan concerning his beautiful presentation. You can just raise your hand. Yes, Dr. Sabir.
Thank you, Flavia. And thank you, Professor Mannan, sir. Actually, we are not actually the expert, but this type of presentation is very helpful for us when we are working it with the neonatology. I'm working with the IKMC implementation research in Bangladesh for the Bangladesh Projanmo site. And one of the things that we are observing in the scan, this is not very technical things, but is a practical issues that we are observing here. Like in the MS Scanu, the CPAP use. Ideally, we should use the disposable circuit for each baby, but because of the cost and other things, this is not possible. So I was wondering, again, this becomes a source of cross infection, as you were saying that. So for the preventive measure, what you are doing in BSMMU for the cleaning of the circuit from using from one baby to other baby the same circuit, sir. So that's my work. Thank you.
Thank you very much, Professor, Dr. Sabir Ahmed. So this is very practical question. So now what we are doing, my teacher, Professor Shudula sir, and my colleagues is here. So now we are using a disposable circuit because you see the infection is in ICU the major killer for newborn babies. So we are using the disposable, but can in case of the situation when the patient, I mean the parents cannot buy, we can use we can use the Cytex for disinfection of this circuit. So ideally, the disposable one should be used. I think sir hand raised is here, sir.
Thank you, Mannan. First of all, a very elegant presentation. You actually captured all from the very beginning of definition down to the management and challenges and everything. Thank you very much for that. I think everyone connected to this particular seminar, they have been largely being benefited. What Dr. Sabir from PRF has asked you, I mean, I think you have rightly mentioned. The best thing is actually disposable one. There is no question about it. And wherever we have a chance, we should do that. But in a very situation where you have very limited resources and you can't actually have a disposable one, then with a very good, I mean, methods, this should be cleaned as Professor Mannan has said with the Cytex, but you have to follow all processes. I mean, you can't be in a hurry or you can't compromise. Then actually, in order to salvage the life of the baby with that machine, you are putting the baby in a bigger challenge with a very serious kind of infection. So there is a huge, question of balance between the two. But again, I mean, whenever you can get a chance, you use the disposable one. I will just add, besides this, what Mannan has said very nicely, for all the people connected to this, that there are few things which are in our hand. And by that, we can actually curb the incidence of infection. That is, one is that often these babies need IV insertion. And if we do not be very meticulous about cleaning the area for putting the cannula down in, and also taking care of the cannula throughout the cannula is in situ, then use of a stock solution, use of your TPN or modified TPN. These are the areas, and whenever we actually use our
Sir, we can't hear you, sir.
Can't hear you. Can't hear me.
Yeah, now it's okay.
I can hear you. Yes, I
Yeah.
can hear you.
And the other thing is that particularly the stock solution, as I said, and using the CPAP machine, I mean ventilation. Mannan has emphasized that one of the big source of infection. So it's not a drama, or it's not that we are putting the baby on a CPAP or a machine. It is more very important thing is that we need to use the clean kind of procedure, so that we are helping the baby with the respiratory support, but we are not putting the baby at risk of infection. So there are many things that we have in our hand. And about antibiotic stewardship, that what he has said, the long thing, there I will draw the attention of all our colleagues, because here we know about it, we talk about it, but we do not practice in many places. We are very, reluctant about following the guideline of using the antibiotics. So we need to be very careful about all these things. So at the moment, I will stop here so that other can react. Over. Thank you very much.
Thank you very much. I have a question, Dr. Sabir. The question about the tubings was about also the CPAP tubings, or was about in other kind of tubings? We're talking about the circuit for the CPAP.
Sorry, say again. I heard some interruption. Is it for
Your question was concerning the circuits, the CPAP circuits?
Yes. Yes.
Yes. Okay. So just to complement the information for the diamedical CPAP in the job aid, we have added how to clean the circuit as an information. So there is the whole process of cleaning. That's not for the autoclavable ones, because there are also autoclavable ones. So some sites receive the autoclavable ones that cannot even go to autoclave. And for those who didn't receive the who don't have the autoclavable ones, all the procedure is written also in the job aid about the cleaning, soaking, and drying.
Yes, I had a look on that, and it is mentioned there bleach. So what exactly
Yes.
Is it hypochlorite solution? I mean, what is that actually does it mean? So
yes. So so this is the Diamedica recommendation, is to wash with soap and water, and then to just remove visible soil, and then to rinse with boiled water or with sterile water. And then they say about then that you can wash either with bleach, either with any other disinfectant that it's a local one. So it doesn't have to be bleach itself. It can be the disinfectant that's used by the local protocol, basically. So if a hospital has a protocol, it can be used also. This is a general guidance. If there is a hospital that doesn't have a protocol, they can use bleach.
okay, thank you. I mean, in the job aid, it meaning it is there like a bleach. So I just wanted to make sure what exactly that bleach means is this. So
yeah,
this is it's a hypochlorite.
Yeah.
Okay.
And there are some bacteria that are resistant to hypochlorite. So for these ones, some hospitals, they know when they have resistance. If you have a hospital that has resistance, you should not use this. You should use the one is recommended by IPC in your hospital, basically.
Thank you.
Welcome. I had one hand that it went down. I think it's Ayomi. I don't know if she still have a question or if it's fine.
Hello, good morning. My hand is still up. Good morning, Flavia.
Hi,
good morning, sir. Thank you for the enlightening presentation. I noticed that in your screening tools, the investigation for screening, you only listed leukopenia and neutropenia. What about leukocytosis and neutrophilia? Because on our end here, we have challenges getting blood culture, even BACTEC that is the shortest one, takes like 5 days to get results, 48 hours to get preliminary results, and 5 days to get results. And sometimes for patients with that are indigent, that is out of their reach. So what about, and we use leukocytosis and differentials, changing the differentials apart from the ones you have mentioned. I just need clarification on that.
Okay.
Thank you.
So thank you very much for your nice question. Before that, I must thank Professor Sudhila sir. He rightly mentioned the preparation of the cannula site and also maintenance of cannula site. This is very, very crucial. And also his comments about the antibiotic stewardship. So now I am telling about the leukocytosis. This is very, very non-specific, but in a late onset sepsis, when the count is more than 25,000, some author they suggest this might be a very weak, though it is weak. Even this might be taken as a skin positive, not only one. It in combination with others, then you can consider this baby might have sepsis, but clinical features should be there. So this is from my side, or other can comment on this.
Thank you, Professor Mannan. If I can also comment on that, indeed, I agree completely. This is interesting because leukocytosis is for early onset sepsis is definitely not a good predictor. As you know, neonates in the first days of life, their leukocytes they can be very high and it can be just normal. And leukocytes, they are influenced by many factors, and so they are probably the less one of the less predictable features in the sepsis screen. But leukopenia and especially neutropenia, and when you use also the ratio from immature to total, this is more has a better prediction, but it's still very low to predict. That's why Professor Mannan was also, if we can go back to his slide, he was saying that all of these sepsis screen, not only the leukocytes, but also the CRP and the ESR, and they are very of low prediction. You can use all of them, and you can use them as an argument based on also clinical signs and the history of the baby, but they will not make diagnosis of sepsis.
Okay, thank you for the response. And that reminds me of a baby we had recently, teenage pregnancy, delivered in the toilet, and the micro ESR was 1, but the risk factors were there. The mother refused to go for antenatal, was doing whatever she liked, despite supervision by the mother and the fathers, the mother-in-law. And this baby came in looking okay, but within 36 to 48 hours, this baby started having features of GIC, bleeding from all orifices. We were planning for exchange, and unfortunately we lost the baby.
We can see one hand from Professor Wazir Ahmed sir. He is very senior most pediatrician as well as newborn specialist in our country. Wazir sir. Professor Wazir sir, I can see your raised hand.
Professor Wazir?
I think
Unfortunately, we can't hear you.
there might be a network issue.
Yes. Maybe. Good. So maybe we could go back to the first cases that we saw in the list in the presentation. What do you think, Professor Mannan? Should we go through that? Should we, Chris?
Wazir sir, Professor Wazir sir.
I'm not sure. There is a lot of background noise, but I'm not sure if it's. I have another hand. No, that's the same. Okay, what I was propose to you, we're going to go through the questions. Meanwhile, let's give some time to Professor Wazir. And Professor Wazir, as soon as you can get a good connection, you can just speak. And we will stop and listen to you. Okay. Okay. Okay, good. I will share my screen.
Hello, Dr. Mannan. This is Professor Dr. Mannan.
Madam, assalamu alaikum, madam.
Islam. Can I give my comment?
Sure, madam. Sure, madam.
First of all, I must congratulate you for your beautiful presentation with the beautiful slides. But one of my suggestion is that what are the steps we will take for the remote area along with the training for the prevention of this neonatal sepsis. Without prevention, we can't reduce the death. So we must now take the step for prevention of this sepsis by anyhow. That is my suggestion. Over.
Madam, thank you very much, madam, for your nice comments. Basically, the prevention part of the neonatal sepsis has already been presented by Pakistan team previously, and I am just only put 3 or 4 slides. The main slide for that is the IKMC, then breastfeeding, then hand washing. So the main presentation on preventive part of neonatal sepsis has already been presented in the previous presentation by Pakistan team. Thank you, madam. Thank you again.
Thanks.
Thank you. So I will just let you, we have less than 10 minutes. So what I propose to you is that we go through the slides concerning the clinical cases. So if you can start screening for those who want to screen. So I just remind you, just screen the QR code and you will be able to enter. And we are going to discuss on these 2 first cases that Professor Mannan has presented in the beginning of his presentation. I cannot see the hands any longer. So if there is any hand, if there is anyone with a question, you can please just ask the question. Meanwhile.
Can you hear me now?
Yeah, sir. Was it, sir?
Yes.
Yeah.
Please.
Thank you so much for your beautiful presentation. I was really enchanted to hear all the things you have said regarding the sepsis. My problem is that we are working in a tertiary hospital where we get referrals from outside. And when these babies come from outside, they're getting most of the antibiotics, even the 3rd generation cephalosporins, meropenem, and all those drugs they have getting. And when we get the babies are already resistant with all these drugs. My question is, if we talk about these preventive measures or treatment measures, these are all within us. But what about the grassroots level people who are dealing with these infections when they are arriving at the places where it needs transportation, it needs treatment? How can we address this vast problem? Otherwise, you see, we'll be getting this infection again and again, and this source of infection will always be there. And antimicrobial resistance is getting so bad, we are left with no drug at all. So I want to hear from the specialists and people who are working on this is how to stop it, where it originates, and how the antibiotic protocol should be maintained. This is a vast problem. It's a huge problem. Otherwise, these, whatever you are talking is very, very sweet to hear. It's very nice to know. And we know it all. So my question is, Professor Shwetala is here. He's involved with the government. How to combat this problem at the grassroots level? Thank you so much.
Thank you, sir. Thank you very much, sir, for your question and also comments. And I would like to refer this question to my teacher, Professor Shwetala sir, as well as Dr. Suman Rao. Shwetala sir is here, sir.
I don't think Dr. Suman Rao is there as well. I think Suman is not connected now. Professor Shahidullah, can you hear us? I will just attempt to respond to comments.
I got a call.
Yes, please go ahead.
I got a call from Harish Sheldani from India. So I couldn't hear the last couple of minutes discussion. Can you say it again, Flavia? What was the thing?
We had a very interesting question, so I will just at the same time I will give you my comment on that concerning on how to tackle this the infection issue, especially in lower levels, lower facility levels. Talking about secondary levels, which are the levels of the facilities in which we are working, which we're working with. This is a very, very complicated question indeed, and this is a very complex problem. And I think this is the question. So the question was what the government can do, what can be done locally, what can be done to improve infection detection, and I dare also to say infection prevention. And also I will add to the question concerning antibiotic stewardship, reduction of exposure of neonates to antibiotics, which is a big, big problem. And it's probably the thing that we can start working on right now. So I'll let your comment, Professor Shahidullah, on that.
Thank you. Thank you, Flavia. I think this is really, really crucial because end of the day, a baby when gets sick, particularly with the infection, sometimes this put us into such a miserable situation that we just sit tight, can't do anything, changing antibiotics and antibiotics, and eventually the baby dies. So rightly being said that prevention, prevention, and prevention. And I don't think it's a very tough thing, but then it is all about our knowledge and mindset and our practice according to the knowledge that we have. If I start with the community, let me share it in two things. Babies are born at home. Babies are born in the facility, which is a reality in Bangladesh, maybe more or less true in other countries as well. So let me talk about the home delivery one, which is the best advice is to tell the parents to go and get the delivery in the facility, but eventually this is not going to happen with all the mothers. So those mothers who are going to be delivered at home, the first and foremost thing is the safe delivery is crucial. It's a blanket kind of thing. Safe delivery means that the very hygienic maintenance of the hygiene throughout the process of the delivery by the service provider and caregivers around the delivery time, and using all sterile kind of things for cutting the cord and all these things. And after delivery, the very crucial thing is starting breastfeeding soon after birth and maintenance of hygiene by the mother and other caregivers. I think those three, and skin to skin contact. So if we can do those things right way, in a very, I mean, uh, in a very logical way and proper way, I would say proper way, this can curtail infection in the community a lot. Then comes to the facility. The facility delivery should be same. It has to be very, very safe delivery, which is again a blanket. I'm not going to talk all those things because that will take a long list of, but safe delivery is one. Soon after the baby should put to the mother's skin to skin contact. Starting breastfeeding, and then maintenance of, I mean, during the whole care, maintenance. And in case of a baby who needs intervention like IV cannulation, CPAP support, or intubation and all these things, again, we have already discussed, Mannan has said everything about that. Please, if we follow that, perhaps that will curtail the infection rate in our babies. So that's what we can do. Regarding antibiotic stewardship, this has been a long and well talked topic in Bangladesh and across the globe. And even in the World Health Assembly, this was talked about. So this antibiotic stewardship, it has got a big meaning. But if I just pinpoint few things for our this particular today's webinar, my suggestion would be that unnecessary use of antibiotic has to be stopped. And whenever the antibiotic will be necessary according to your that is called criteria to introduce antibiotic, then you use the first line, second line, third line according to the unit protocol or hospital protocol. And again, review the antibiotic, an antibiogram, and changing of the antibiotic protocol time to time, which I am not going to say like, will it be 6 months or 3 months or 1 year? I'm not going to say. The unit or the hospital has to have a policy on that. So if we can do all these things, and particularly I would say unnecessary use of antibiotics, switching antibiotic too frequently without having a proper logic, just seeing that the baby is not improving for 24 hours, changing the antibiotic, which is quite rampant practice in our country. We need to stop all those things. So I'll stop here, and if anything comes up, I'll talk. Over.
Thank you, Professor Shahidullah. Very, very well said. Very complete answer. I will add that we will soon release another job aid, which is a job aid for management of infection. So it will be able to support some of the district hospitals, especially regarding when to stop antibiotics, to help also stopping antibiotic earlier and reducing exposure of these babies, which will also reduce their risk for infection, for a new infection, for necrotizing enterocolitis, and reduce the risk of increasing resistance in your units. I have another hand. Professor Wazir, your hand is still on?
There are two hands I see, Flavia, in my slide. Yes. One is Naima, one is Wazir Ahmed. Still their hands are up.
Yes, Professor Wazir, you still want to, your hand is still in the first place, so I don't know if you have something to add, or it's an old hand.
Yeah. That's an old hand. Okay, go ahead. Just I want to make one point. I want to make one point to Professor Shahidullah. You see, the allocation of budget in our country for the health system is so low, it's 1 to 2% of the GDP. And WHO recommends that the allocation should be nearly a little bit about 5% or more for the health system. Financial support from the government, you cannot do anything. You can't train people. You can't reach to the people unless and until you have a budget. That has to be emphasized to the government level. that the budget increment and training of persons all involves the monetary involvement. Like Sri Lanka has, most of the babies are born in institutions. They're a country like ours. If they can do it, our education system, our health system is really in a very messy condition. I don't know. This is a very grave situation, and we are seeing a very dark future ahead. This is my final comment, and I want to put down my hand. Thank you so much.
Thank you. I will just give the word for Dr. Naima. You have your hand on.
Naima Firdaus Shanta.
Ji. Congratulations, sir, for your excellent presentation. I want to know where the in periphery where blood culture and CSF service is not available, how long we should continue antibiotic? Is it safe to give antibiotic for 14 days?
This is again a very crucial question. So basically, I think in that case, if
Is it a problem from Mannan's end or our end?
I
Flavia,
think it's
can you-
Professor Mannan. He's
Oh.
froze. We lost
Yeah,
him.
I mean, internet problem might be. I can take a chance
Yeah.
for responding to this.
Please go ahead.
Naima, thank you very much for your very pertinent question, because most of the time that our clinicians have to work in a situation where they cannot do the blood culture and other things. And you are sure that this baby is septic clinically. And some other support like your liver, I mean, white blood cell count like leukopenia or high leukocytosis or CRP, and then combined with your findings, you need to give antibiotic. But you are blind because you do not have the culture facilities, CSF facilities. But in that case, my take, what I used to tell my students, that go for 7 to 10 days in case of without any evidence of suspected meningitis. But if you have the evidence of meningitis like bulge, fontanelle, convulsion, or other things, but you cannot do CSF, and the baby was improving on antibiotic in a slower mode, certainly you can go for 2 weeks. I mean, this is for only on those situations where you are dealing with a biclinical, your equipment says, your mind says that this baby is septic and with associated with meningitis, but you don't have any culture facilities and CSF study. So you can do that. So, and see the improvement of the baby. I will stop here.
Yeah, thank you, sir. Sir, sorry, sir, I was disconnected. Thank you, sir. I think this is the right answer. Thank you very much, sir.
I would just add that if there is a baby that you started antibiotics and you were not sure, or there was any other explanation, which is not this baby, but for example, as we explained in the beginning of the presentation, Professor Mannan presented a baby that was 33 weeks that has respiratory distress and was born from cesarean section and didn't have any other risk of infection. This baby, he wouldn't need antibiotics because we could explain his respiratory distress on RDS. But even if you are not sure and you give him antibiotics and he improves fast, this baby could also stop receiving antibiotics in the first 48 hours, even if you don't have blood cultures, because you have another explanation for that, and because the baby improved fast. So this is the other end of the medal, and these are the babies that would be good to shorten the treatment when you have another explanation, and or when you rule out sepsis because there is an improvement that's done very fast. I think I have many hands still going on. I have a Professor Wazir again, and I have also Naima. I just ask Naima if her question is answered.
I think these are the old hand.
Yeah, I mean,
It's on all hands.
I would say
Okay.
whoever raises the hand, and if you are satisfied with the answer, please lower the hand. Otherwise, it's difficult for Flavia to know who is hand says is still up and not. Naime, are you okay? In that case, lower the hand.
Okay.
Mannan sir, can I ask a question?
Yeah, Parvez, sure.
Ye-
Dr.
Assalamualaikum,
Parvez.
sir.
Sir.
Sir, one thing is about antibiotic, second line antibiotic. You have showed us the second line about using cephalosporin. So one thing is we already not
Hear you,
using.
Parvez.
Sir, sir, can you hear me? Hello, am I audible?
Yes, we can hear you. Yes, you're audible.
Okay. Sir, you have shown that second line antibiotic is cefotaxime and other ceftriaxone. So far, another was ceftazidime once upon a time. Now it is not being used in my hospital because last 2 years I have found no patient was sensitive to ceftazidime. So I have discontinued ceftazidime, but we are using cefotaxime when there is a suspicion of meningitis. But we are not using ceftriaxone. And another thing written in the book that try to avoid these drugs because these drugs have a increased chance of fungal infection. So what is your comment about this? We are not using ceftriaxone in our department.
Thank you, Parvez. So you are right. Basically, it depends upon we also are not using the ceftriaxone in our department. You know very well. And in terms of ceftazidime and other drugs, it basically depends upon your culture sensitivity report for the last few months. That's why we have to review the cultural sensitivity report in a periodical interval. I mean, in every 6 hours. What we are usually doing in our department, every 6 hours, we are reviewing the cultural sensitivity report, and we are taking decision what should be our first line antibiotic and what should be our second line and third line, like that. So this is from my side.
So thank you, sir. Thank you.
You are welcome.
We are also doing the same.
Thank you. So I think we have had a very nice discussion, and we will not have time for going through the quiz. We are already 13 minutes past our time. So if there is any burning question, you can please raise your hand. Otherwise, we will. I will keep the chat open. So if there is any question on the chat, you can ask, and we will try to keep the discussion going on there. And I'd like to ask Professor Mannan if you have any other things to add and final message before we close.
I no question. I just wanted to make comments about. Thank you very much, the team, for giving me the responsibility to conduct this seminar as a speaker. And thanks to all my teachers who joined here, my colleagues, my students, and I am very happy to hear their voice in this platform. So thank you again from my side.
Thank you. And I can thank you from our side for your participation. And thanks for all the teams. So all the teams from Bangladesh, from Ethiopia, from Pakistan, and from Nigeria, and also from the teams from IKMC-IR that could connect to some other seminars. Again, as I said in the beginning, this is the last of our series of 8 seminars. All seminars are available on our YouTube channel that we have been sharing with the teams. Sorry, there is someone. Okay. So the seminars are available on our YouTube channel that we have been sharing with all the teams. So please don't hesitate to share with your teams if you wish so. And I will close here. Again, I would like to remind you that we have just shared our CPAP job aid, and we'll be soon sharing our management of infection job aid. And we are going to be working on job aids for all the domains. And meanwhile, again, follow your protocols and always think about stopping antibiotics when you rule out infection. Thank you very much. And thank you again, Professor Mannan, for your participation, and have a beautiful evening.
So thank you, everybody. Bye.
Thank you.
Thank you, and you too.
Thank you and bye,
Thank
everybody.
you.
Assalamu alaikum.
Thank you. Bye. Bye.
Thank you. Bye.
Thank you. Bye.
Thank you very much. Goodbye.
Thank you very much. Bye.
Bye. Thank you.